those who are joined and are joining in. We'll just give it another 30 seconds and then we'll kick off. Okay, right, ladies and gentlemen, it's time, so we'll start. A very good evening, ladies and gents, and welcome to the 9th episode of the British Hip Society Midweek Special. I'm Vikas, Khanduja, consultant orthopaedic surgeon in Cambridge and chair of the Education Committee, and it's a pleasure to welcome all of you to this webinar. Now, our aim with this series has been, as you're well aware, to bring you clinical cases and discuss intricacies of decision-making and management from key opinion leaders in the UK, so that we can continue to fulfill the Society's manifesto of sharing knowledge and improving patient care. We've had 8 excellent sessions on the primary hip and the young adult hip, and now the last 4 sessions are dedicated to revision hip arthroplasty. Today's topic is focused on infection, and moderating the session today would be our president, Mr. Andy Hamer from Sheffield, and we also have a stellar faculty with us today, and I will let Andy introduce you to them in a minute or so. We're also delighted to be collaborating with OrthoTV Global, who are celebrating their 10th anniversary. Many congratulations, Ashok, for this series, and they've been excellent over the last 8 webinars. And we welcome all the viewers from the Asia Pacific region who are able to watch this event streaming live at no cost via OrthoTV. We strive to make every session as interactive as possible, and therefore please do post in your comments in the Q&A box. Our panelists will address these questions as we go along and choose some of them to be discussed live at the end of the webinar. For those of you who are not able to join us live for any reason, we also have the option of on-demand viewing via our educational platform, Penopto, on our website. So please do log in. Once again, a very warm welcome to all of you, and hope you enjoy this evening and the series as well. Andy, over to you.
Thank you, Vikas. I echo your welcome to everybody, particularly those joining live on OrthoTV. The Hip Society is making great efforts under Vikas's leadership of the Educational Committee to improve our offering, not only in the UK, but across the world as well. So delighted to see you all joining us this evening. So this evening, we're going to be addressing the problem of periprosthetic joint infection. Periprosthetic joint infection is the worst complication that can occur after a primary hip replacement, and in many people's minds is the most difficult in many ways to deal with. Thankfully, it doesn't occur very often, but when it does, it has devastating consequences to the patient and also often to the treating surgeon, who can often take this as a personal problem that has occurred. So I'm really delighted that we're joined with 3 experts from the UK who are going to help us this evening. We're going to start with my colleague Richard Westerman, who's going to talk about the diagnosis of PJI and the treatment through debridement, antibiotics and implant retention, known as DARE. We're then going to be joined by Jason Webb from Bristol, who's going to talk to us about 2-stage procedures for the treatment of periprosthetic joint infection. And then we're going to wrap up with Tim Petherham, colleague from the Northeast, who's going to talk about single stage with some of the controversies that surround that particular treatment modality. So please ask your questions on the chat function. I'll be keeping an eye on that. I'll moderate the questions. What I propose to do is that we're going to run through the 3 talks together, each of about 10 minutes, and then have a panel discussion prompted by the questions that come through on the Q&A. So I'd like to invite Richard Westerman to start the session talking to us about the diagnosis and the acute management of PJI, including DARE. So Richard, over to you. Thank you.
Apologies. Hello, my name's Richard Westerman. I work in Coventry and I'm also a member of our bone infection group for Coventry and Warwickshire, which we call the Big Cow. Essentially, it's a fantastic bunch of colleagues working together to try and solve these difficult cases. So what exactly is a DARE? It's the surgical management of an acute periprosthetic joint infection using a debridement, antibiotics, and implant retention to achieve infection eradication. Now, looking back at the literature, I find it really fascinating to see the significant learning curve our profession's been on over the past 20 years. In 1998, the Mayo Clinic described 42 acute infections with a mean follow-up of 6 years. Only 6 patients were managed successfully. Zimmerli in 2003 recognized the chaotic nature of many incomparable papers on this subject. And he started a conversation on the need for timescales and symptom onset, initially proposing 3 months. The Oxford Bone Infection Unit in 2009 described their protocol of surgical debridement, microbiological sampling, early intravenous antibiotics, and prolonged oral follow-on antibiotics, which they called a DARE. They recognised that the risk of failure with this strategy rose after stopping oral antibiotics, but lengthening the antibiotic therapy simply postponed rather than prevented failure. And even by 2019, the Mayo Clinic described an unacceptably high failure rate of a DARE. So they implemented a double DARE, a 2-stage debridement protocol that included the insertion of high-dose antibiotic beads between stages for the treatment of an acute PJI. And they reported reasonable success rates. However, 55% were still on long-term antibiotics. I suggest these cannot be described as successful eradications, despite having the morbidity of 2 operations. 8 years of data from the Swedish hip arthroplasty registry emphasises the need for modular component exchange as part of our DAREs. And this really helpful review paper from Edinburgh clearly summarises practice in the UK over the past 20 years and the significant improvement in our results. The 2 key improvements over this time have been the timeline to surgery and the exchange of the modular components. This illustration demonstrates the very important relationship between symptom onset and the timeline to surgery in terms of successful outcome, with much higher rates of success in the first few days. Sadly, there is no simple test for hip infection. Diagnosis is made based on standardized diagnostic criteria with varying degrees of certainty. The International Consensus Meeting in Philadelphia in 2013 identified the need for 1 major criteria or at least 3 minor criteria for the diagnosis of a PJI. The second Consensus Meeting in 2018 went a step further and attached scores to some of the minor criteria to distinguish the merits of each. And most recently, the European Bone and Joint Infection Society have categorized the likelihood of infection based on clinical, laboratory, and radiological features to create this really helpful user-friendly table, which is well worth having another look at after this talk. So what should we be doing? It's really quite simple. We need to identify the organism and treat the infection. This requires meticulous sampling, ideally with 5 samples. An aspirate should be taken before giving any antibiotics wherever possible. 4 tissue samples should be taken from different areas using sterile sampling trays with sterile sampling bottles. Once instruments are used, they need to be discarded rather than placed back in the same tray. And your theatre team need to be aware of this to avoid contamination. If you haven't already got sterile sampling trays, this is an easy win for improving the diagnostic accuracy in your unit, and I encourage you to make them happen. Please bear in mind that skin swabs are of no diagnostic value and a source of frequent confusion for arthroplasty patients. And then we get on and treat the infection. Prompt decision-making is essential, aiming to establish if there's an acute, post-operative or acute hematogenous PJI present. We've all been there when even the patient tries to persuade us that all is well. It's really important to consider involving an impartial colleague to consider the case objectively. Now, the hip will not turn into a pumpkin after 28 days. Every day matters. Early surgery is critical, and purely getting it done in the first 4 weeks misses this point. Looking at our own data from Coventry, we have an 88% success rate within 1 week of symptom onset, whereas 62% success rate if the day is within 4 weeks of surgery. So please don't delay until the next bone infection group MDT, but do discuss early with a colleague as needed. We're aiming for an aggressive debridement, which must include a radical synovectomy, aiming to treat it like cancer surgery, leaving no cells behind and removal of all avascular tissue. In reality, we're trying to reduce the bacterial burden to enable the body to fight the infection. All modular components need to be removed to clean all possible interfaces of the components and allow adequate exposure. Copious lavage, we use chlorhexidine wash. Consider topical antibiotics with antibiotic carriers such as stimulant. Of note, there's no role for arthroscopic debridements, for definitive DARE surgery, for hips, or for knees. There's been lots of discussions on the merits of 6 or 12 weeks antibiotic duration, with the majority now favouring 6 weeks for hip replacements. Long-term suppression is not the same as successful eradication. In the modern climate of antibiotic stewardship, long-term suppression should be avoided for the majority, but ultimately it's an individual decision for your regional MDT. There needs to be a critical examination of the implant interfaces, and this can only be achieved following a thorough debridement to expose the implant interfaces. It's best achieved by trying to pass a blade around the interfaces of the stem and the socket. So when writing the British Hip Society surgical gut standards for PJIs, we were clear-minded that DARE procedures should be performed in the primary centre by an experienced arthroplasty surgeon, adhering to the consensus and modern DARE principles you've heard here. We should not delay surgery for a bone infection group discussion. A DARE lends itself to being performed in the primary centre because the modular components need to be readily available, and the approach following an acute post-operative infection should be the same as that for a primary surgery. If the DARE fails, it should not be repeated unless there's exceptional circumstances, and it certainly warrants discussion in a bone infection group MDT and ideally transferring to a specialist centre first. There are occasions where a DARE is not recommended, in the presence of a sinus, loose implants, fungus, or multi-resistant or atypical organisms. And it's worth being cautious in the immunocompromised patient. Managing PJI cases is hard, and it's exhausting. You need the support of a great team to manage these cases effectively, meeting formally at least every 2 weeks. In our bone infection group, we have a formal meeting with a consultant microbiologist, consultant infectious diseases, our pharmacist, our advanced nurse practitioners, the operating theatre coordinator, consultant surgeons, arthroplasty fellow, as well as our trainees. It's amazing how often a plan's almost clear when our pharmacist or our nurse practitioners will provide key information that completely changes the outlook. The contribution of the full team is the key to our success. Considering our starting point for these cases is fairly dreadful, with a known periprosthetic joint infection present, I think the results from a well-performed DARE are remarkably good. Early decision making is so important. Do involve a colleague if there's any doubt. The surgery requires a thorough debridement by an experienced arthroplasty surgeon and must not be squeezed onto the end of a list or left to the junior trainee. And don't make assumptions on antibiotic choices. Start broad and then involve the bone infection group. Thank you and good luck.
Richard, thank you very much. A very comprehensive outline of diagnosis and the treatment via DARE. A lot of questions will be raised by the rationale behind it, and obviously there'll be some questions, I'm sure, about your technique. But like I said, I think we should press on. We'll take questions via the chat function, and we'll go straight to Jason Webb, who's going to now continue by talking about the option of two-stage treatment for periprosthetic joint infection. So over to you, Jason. Thank you.
Thank you, Andy, and the committee for asking me to be involved. So yeah, I'm Jason Webb. I help run the regional prosthetic joint infection service in Bristol in the UK. And I'm going to talk to you about the two-stage. These are my disclosures. And this is the outline. I've been asked to talk about the central importance of the MDT. You're going to hear that 3 times tonight because that's the key. It's the new gold standard. A brief talk on touching on some of the surgical technique, but I've been asked to mostly focus on some cases. When you run a regional service, you'll get your referrals from all sorts of areas, from without the hospital, the DGHs around you, or from within your own. But the thing that has changed, the world of PJI has changed. It's a complex management problem and it needs more nuanced thinking. And that is where the MDT has become absolutely vital. We have to thank people like Zimmerli and Trampus for heralding in this new era. When I went to talks 20 years ago, when I was getting interested in PJI, you would have centres that only did 1 stage, only did 2 stage, and they would tell you about their results and try and differentiate them. But we know now from systematic review and meta-analysis that there is no significant clinical difference as regards treatment of the infection from a 1 or a 2 stage. And in fact, this is a continuum of management, as I'll show. But what has changed, and what does have absolute evidence within the literature of proving benefit to the outcome of these patients, is that they are managed in an MDT, not a standalone surgeon with an uninterested microbiology department, but a team, as Richard has just demonstrated, who help the surgeon so that you don't feel on your own when you're making these decisions, but more importantly, help the patients. Here's the members of our team, okay? So just like Richard, it's a big team and we all meet and we run our MDT and the clinic simultaneously. So we then make the decisions or come up with the plans and go and explain them to the patient. One of the benefits is you investigate your cases better this way. And as I say, this allows you to attribute the most likely means by which you're going to manage this case, whether it's a DARE, through exchange arthroplasty 1 or 2 stage, or all the way to excision, or when you need to say surgery is probably not going to help and you need to use antibiotic suppression. Now, the aims of treatment for prosthetic joint infection are to eradicate the infection, or probably nowadays we need to think about putting these patients into long-term remission whilst trying to preserve joint function. And for that, you're going to need a cunning plan. But all of those cunning plans with a surgical approach will require 2 key elements, and that is thorough surgical debridement combined with a prolonged course of antibiotics. So this next little section, I've been asked to touch on a few areas, not exhaustive, but just to reiterate that if you are going to operate on this, you will fail whatever tactic you use unless you do a good surgical debridement. Now, one of the first things is when you need to excise the wound. We can maybe discuss that in the question section later, because that, again, is quite subtle. But if you are going to excise the wound, I always use the 2-blade technique. The 2-blade technique is quick and it's neat, and it allows me to close the wound at the end in the majority of my infection revisions with a subcutaneous quill and then gluing things on the top. And I think when you can seal in these cases, that gives a better outcome. The following few photographs are from my time at the Endo Clinic, and you can see here they don't use a 2-blade technique, and you get a much less neat incision. But straight away, you can see the importance of radical debridement of all of the infected tissues going down through the sinus tract. Sampling, as Richard has already shown, is vital, and you need to do it well. And we likewise use an Oxford type technique and get it to the laboratory quickly so that you're not losing, losing those anaerobic bugs or whatever. And again, no swabs. So a couple of slides on the radical debridement. You need to remove the biofilm, and the biofilm is on your implants, your cement if you're using it. Any infected, dead, necrotic tissue, all of those are the perfect substrate for the biofilm to not only be present, but to form. If you don't remove these effectively, you will leave a large inoculum that will give an early recurrence of your treatment. A very late recurrence, we really can't be accused of, but an early recurrence means your treatment has failed and you put the patient through all of this risk. So you need to get everything out. In our unit, we try and do most of these major infection revisions as a dual consultant. You've got the benefits of the MDT, where many consultants are present and have helped make the decision. But in the operation, we will have various plans. And to have another experienced infection colleague there is really helpful. So again, I would stress that if you are going to be taking this on as a specialist interest. But part of your plan from the NDT is when you think you might need to use more extensile approaches to remove all of the biomaterial whilst preserving bone and joint function. You need to remove everything if you can. And that needs to have then been part of your strategies, your plan A, B, C, D, and E on how you may reconstruct and whether you think this can be a 1-stage or a 2-stage. As regards the soft tissue debridement, when you operate on these cases, as you know, there's this field of bleeding which you can't control with diathermy. You've got to preserve the artery and the nerves, but when you move beyond that fibro-inflammatory field and have debrided into more normal tissue that does not bleed from every part of its surface, I think that's the best indication you can have that you've debrided enough. You start at the base and you move to the surface, or that's what I do. And here's the classic photo from the end of the clinic showing just how radical that debridement can be. So in the remainder of my time, I'm going to show you some cases. We're going to go old school to begin with. 15 or so years ago in my practice, when I was just starting off, this was how we would manage these, even via MDT. A 74-year-old man with comorbidities had both hips done in a treatment centre near us, but it had never been right infection. Inverted commas, there'd been a superficial wound infection, which also in inverted commas, they had managed and treated with IV antibiotics. But we know from the basic science that can't work. He continued to be in pain and was referred to our service 1 year post-op, and he had an irritable hip. So that is not what you expect from any one of your normal hip replacement outcomes. The X-rays, well, technically not that well done hip replacement, but no different to the asymptomatic left hip. But if you zoomed in, there was progressive lucency in all 3 zones of the acetabular component. And the blood test confirmed that we have to be worried that this is infected, a CRP at a year of 54. So we then do an urgent aspiration. We now combine that with biopsy, and it grew a sensitive coagulase negative staphylococcus, which is the leading cause of infections in the UK and definitely in our region. So he then comes back to the next MDT clinic. And at the time, we made the shared decision-making with this patient to do a 2-stage. Nowadays, I think we would have managed this as a 1-stage. But anyway, we did a 2-stage. So there's the first stage, not particularly well done. I don't use off-the-shelf spacers anymore, but I do still make bespoke antibiotic beads, cement beads, based on the cultures. We've always in Bristol done an early oral switch. So IV vancomycin to begin with, then you get those great results from your meticulous sampling with your antibiogram, and you can do a focused early oral switch when the CRP in our unit, we go once it goes below 50. The CRP came down, stayed down. So we do our third MDT, again, joint decision making, and we say we can go ahead with the second stage. And by having had everything under control, that lets us reconstruct in a relatively simple hybrid type construct. So that is one of the benefits of a 2-stage. Everything is under control and you can make your decisions. This patient was still infection-free when he passed away 9 years post-op. But there are other reasons. We've changed our indications. It's very subtle based on your MDT, based on patient factors, antimicrobial factors, microorganism factors, and soft tissue factors. So in a few very quick further cases, I'll illustrate those in turn. First one, a young student from overseas studying in the UK, had hip pain, was treated elsewhere in the country and had a hip resurfacing. She moved regions and then was admitted to our hospital as an emergency with sepsis. The radiologist aspirated the hip and it looked frank white pus, and they were concerned it might be TB. She deteriorated, so I had to take her urgently to theatre. But the group, the microbiologist and the other surgeon said we should do this as a 2-stage. So that's what we did. Spacers, some beads in, but no spacer. And this was a super infection of a staph epidermidis again, together with the underlying pre-existing TB. Infectious diseases and microbiologists work together with an anti-staphylococcal and an anti-TB regimen. They wanted us to keep the TB treatment going for 6 months before we operated. But again, things were more under control. So a simple reconstruction with a hybrid type construct, continued anti-TB treatment for a further 6 months post-op, and 12 years post-op, she still has good function and has not had a relapse of her infection. Polymicrobial is one indication, or really weird bugs, or if you've got fungal infections. Next, resistant organisms. More recent case, 73-year-old lady, the biopsies had shown a really resistant E. coli for a late hematogenous infection, that the microbiologist said, please do this as a 2-stage because we've not got any good oral antibiotic treatment, and actually very few IV ones. So I favor a Kumar's type spacer nowadays. We got the better sampling, gave us a much more precise antibiogram, so it could be all reconstructed with uncemented implants as a controlled fashion. So resistant organisms is another reason why I think you could consider in your MDT. Culture negative is another one. Here, a patient who had a hip fracture that had a total hip replacement, but was referred to us with rapid early loosening and periostitis. So we know it's infected, but after several biopsies, still nothing yield on growth. So the microbiologist said, please do it as a 2-stage. So same type of process. This grew the fortunately sensitive but rare Capnocytophaga canimorsus, and then we can reconstruct in a controlled fashion. You've always got a 2-stage as a backup. So here's an emergency case that a young fit patient who was admitted to one of our regional DGHs, septic and unwell. So he'd had previous revisions for metal on metal case, but they did the difficult work for us, got the implants out, got the great samples, referred to our MDT for the definitive reconstruction, but we had everything we needed, so we could do that in controlled fashion here with a gap cage type reconstruction. But it's all controlled. You get the patient well and stable. Complex reconstruction, the penultimate one I'm going to talk to you about. Here, an elderly man with a resistant bug, very little bone around the proximal femur apart from his heterotopicus ossification. And so we agreed that this should probably be done as a 2-stage. And that even was more obvious when we'd done the first debridement. There was a delay through medical reasons, but we were able to get, through CT scanning, get a custom-made implant designed and combine that with a proximal femoral replacement. His only wish was to be able to stay in his own home. And 2 years post-op, he's off antibiotics and still living independently. The final reason to do a 2-stage is you've always got it up your sleeve if you get in trouble. Here was a case through our MDT where we told the patient we would like to do it as a 1-stage because they had a sensitive organism, but we might have to bail out to a 2-stage. And the team who were operating the patient became quite unstable about an hour and a half into the operation. There was a small perforation of the femoral canal when they were removing the implants. The anaesthetist said, please stop, we want to stabilize the patient. So they had a 1st stage, no spacer, but the patient could be stabilized, the infection could be treated, and it then could be managed in a controlled fashion. So that's what a 2-stage gives you. So in summary, the MDT is the new gold standard, not 1 or a 2-stage or any fights therein. It allows you to counsel your patient, to tell them and your colleagues your plans, and it's always available to do a 2-stage if you need it. These three references, I think, are key in heralding in this new era, and I would recommend them to you. Thank you very much.
Jason, thank you very much. Very comprehensive and some very difficult and outstanding cases. So that's fantastic. Many questions coming to my head after your presentation. So without further ado, we'll go to Tim Petherham, who's going to give our final talk of this evening, and then we'll open up for questions after that. So Tim, thank you, and over to you.
Thank you, Andy. Hopefully you can see and hear my presentation. So I'm Tim Petherham, revision arthroplasty surgeon from Northumbria in the north of England. There's Hadrian's Wall, and I'm going to talk to you about single-stage revision for infection. Thanks for the invite. Just need to get slides working. Here we go. So I'm going to kick straight off with a case, actually. Very lucky to be doing the third talk where my colleagues have covered really all the important topics, and the single stage becomes a bit of a nuance of that. As Jason alluded to, essentially infected revision work has absolute parallels all the way through from DARE through single stage or two-stage revision. The fundamentals are all exactly the same. It's that debridement and the MDT working, getting the right antibiotics, that's absolutely crucial. We're going to kick straight off with a case for single stage. So this was a 78-year-old lady who was actually very well lady, but had developed an arthritic hip and had a cemented hip replacement in 2018. Just to note in her history, she did have some wound leakage really up to 2 weeks, but it did stop just before 2 weeks, which would normally be our cutoff for intervening and considering DARE unless there are other problems. And that was controlled with suction dressings and that actually settled down. So here was her arthritic hip. Note the other hip on the other side, which isn't terribly well done, but she had no problems with. And that was her left cemented hip replacement, which she was very happy with. However, she re-presented us a year with 2 or 3 months actually of gradually increasing symptoms again. It's pain. Patients with infection present with pain. The capsule and the hip are inflammatory. They've got fluid in them. Sometimes the implants are coming loose. So it's usually pain that presents with a more chronic infection, and that was her case. She had pain in the groin and a bit through to the buttock. She had pain at night. And from being active and delighted with her hip replacement, she was limping with a stick again and back to square one. On examination, as Jason's described with his case, the hip was very irritable to move, which you wouldn't expect from a happy hip replacement. Although from the outside, as always with a hip, unless things have developed quite a lot, there was nothing to see. The hip's deep inside, and the scar looked fine and was quiescent. So as we always would work up any painful joint replacement, she went round for x-rays, and here we can see her x-rays, and these show rather nicely findings that you wouldn't expect a year after a hip replacement. So she's got a very clear lucent line all the way around the socket in all 3 zones, and actually looking closely, one can even imagine there's a bit of a line forming in zones 1 and 7, i.e. at the top there of the cement bone interface around the stem as well, which again we wouldn't expect to see. So there's clearly a problem with this hip replacement. She's got pain. So what do we do next? So we follow well-published algorithms for looking into these patients, and we investigate her with some tests. So blood tests are the first step. We normally do a CRP and ESR, and sure enough, they were raised. The CRP was elevated, the ESR was elevated, the white cell count is often normal as it was. So those raised inflammatory markers combined with all the rest of it start ringing quite loud alarm bells in your head. And you need to be thinking infection always with any painful joint replacement, but particularly when these things start coming together. So the next step is an aspiration, as Richard told us in his talk, and that's what happened. So in our trust, we're very lucky. All our aspirates are done by a specialist nurse who's very, very experienced and does actually a few hundred a year for us, which means he has a very high hit rate. So we usually get a good aspirate with a good result, which is very helpful. And he's published on that there. So the aspirations are done in theatre. We send the samples actually in blood culture bottles, aerobic, then anaerobic in preference. And if there's some left in a universal container, this yields high results in literature, and that's our current practice. We do sometimes do a white cell count and differential on the synovial aspirate as well, if there is enough. So this patient grew a Staphylococcus epidermidis. Again, like Jason, this is our commonest sort of infections that we see. And it was a very sensitive organism, luckily. She did have raised white cells and differential on the synovial fluid as well. So it's become clear this lady has an infection in her hip. And again, as my colleagues have made very clear, the absolute next step for her is the multidisciplinary team. So we also have a weekly MDT where we gather with our microbiology and infectious diseases colleagues, among others, and multiple revision surgeons. And we share our experience and in inquisitive minds to come up with the best plan we think we can for each patient. So this lady has certain features which predispose her as suitable for a single stage revision. We have a known organism from the hip. This is a sensitive organism to multiple antibiotics in a lady who's well and has a normal immune system. Bone stock-wise, as you've seen, it's reconstructible in a single stage. There's no large defects or complicated factors there. And her soft tissues are in good condition and very much suitable for a good closure, primarily. Then the conversation comes around to the microbiology aspects. We often involve the pharmacist at this point, depending on other drugs that the patient's taking and so on. And the microbiology gives a nice, clear plan for the surgery. So in the surgery, our predisposition, again, is to use the revision cement pre-mixed with antibiotics. We use Copal-G&C with gentamicin and clindamycin. That dual antibiotic cement has been shown in the literature to be good at clearing infection and better than home mixed cement or single antibiotic. We add in a gram of vancomycin in this case per mix, but again, it's decided by the microbiology team that, and sometimes meropenem, and again, they need to be involved. We're going to give the patient ticaplain and gentamicin at induction, partly to cover the infection they've got, but also we're doing another revision procedure and we don't want her getting another infection. So they always will have antibiotics at induction. And then we will continue an intravenous antibiotic post-operatively while we await the cultures. And as Richard mentioned, we start broad with that. So for her, it was ticaplain in post-op, continuing until we got the culture result, because we've grown something on the aspirates. But it is possible and sometimes does occur that we find other organisms on the intraoperative samples when we've got a bit more tissue and information. And our normal practice in our institution is for a week of IV antibiotics, usually if everything's going well, and then an oral switch with a total of 6 weeks antibiotics, usually 1 week of IV and 5 weeks of oral. Occasionally you need IV for the whole course. All depends on the organism. But again, the crucial thing is the MDT, taking learned advice and a good discussion. It's certainly not something the surgeons describe. I'm going to mention very briefly Solario trial at this point. This is a trial between long and short-term antibiotics. As I say, our standard practice is definitely 6 weeks, occasionally longer if they're stubborn organisms. But Solario is looking to see if that's really necessary. Multi-center prospective randomized trial in the UK that we're recruiting to at the moment. So we'll see if that guides us any further, but this is our current practice. The surgery, Jason's done some fantastic slides there and made it very clear how you do the surgery. The surgery for a single stage, and in fact a DARE, bar the implant removal, is exactly the same for a single stage revision. The surgeries are all about that careful debridement. Just a very small note, I tend to use an extra drape on the top, so there are different ways of doing the single stage surgery. Some people just do one continuous operation, some people very much do a 2-in-1. So do the first part of the operation, the first stage, if you like, then properly pause for some time, 20 minutes, come back and do the second stage. I do it as one operation, but I do have clean gowns and drapes and trays and so on. And this drape is quite useful to put over the top for the dirty phase of the operation, which can then be cut and removed, leaving you with clean drapes. So Jason's been through the surgery in more detail, but for my single stage, I'm definitely using the double knife technique to excise the scar. I think that's a lovely technique, just makes your closure so much better. And I thoroughly agree with that. We're going to do standard approaches to the hip, usually posterior for me. And we're going to do the standard tissue sampling, 5 tissue samples, as everybody's mentioned there. That's clear in all the guidance that's out there these days. And no swabs, as everybody said. We're going to do the explantation phase and the traditional aseptic revision surgery. Everything must come out, all foreign material. Again, just as Jason and indeed Richard said. The debridement is the absolutely crucial bit. Any infected tissue must come out, as well as all the implants. And it's all about the debridement, I think, that leads to success in this. this treatment. The treatment of infection is surgical and antibiotics, and the surgery is all about the debridement. Thorough irrigation. I'll then do a degree of chemical debridement, or at least antiseptic. We use povidone iodine. There are various things you can use. So I will do the first dirty phase of the operation, get everything out, debride it all to my satisfaction, have another look after the irrigation, probably more debridement, then pour in the povidone, take off that top dirty drape, and then the scrub team goes, changes into fresh gown and gloves. The drapes are now clean. We have fresh instruments, and then follows the clean part of the operation, which is the reimplantation phase. And often in Northumbria, we're heavy cement users anyway, and we will tend to use a cemented implant for the reimplantation unless the bed is terrible for cementing, in which case you can use uncemented implants for your single stage. The literature does support that. As I say, we tend to use cemented. So this was her revision. As always, we like a revision to look like a primary, and her left revision hip replacement there looks rather like a primary. Again, it's cemented with the extra antibiotics, and we were happy with that. This is a bit more recent. I'm a bit younger than Jason, and this was only 2 years down the line. She remains infection-free and very happy with her hip. So the literature's been alluded to. Certainly, there's pretty much equivalence between 1 and 2 stage in the literature. The literature mainly consists of case series. It's retrospective reviews often. We don't have the best literature in the world yet, but people are working on this. The Bristol group are contributing to that, and they did a meta-analysis to guide them with their multi-center randomized study they've now done. And this showed pretty much equivalence of single and 2 stage. Note the block for the 2 stage, the lower block on that graph, is larger with tighter confidence intervals because there are more series of 2 stage than single stage. But hopefully the INFORM trial, which is now complete thanks to the Bristol group's leadership, is a multi-center prospective randomized trial of single versus 2 stage revision, and will help guide us a bit more when to consider this. The results are complete and out for publication, I understand, so we will see. I have to mention the Bone and Joint Infection Registry as well, as which I'm an executive member of. And again, we're hoping to help answer many of the difficult questions around infection with a registry type approach, where we're gathering large amounts of data from across the UK for gradually, hopefully, all infected cases that are done, so we can look at which organisms might respond better to different approaches. Other things like, do we put stimulant calcium beads into infected cases? Do they work or not? So it's not our current practice in Northumbria, but it's certainly widely used, but the literature is very poor in it currently, and the registry might help with that. So there's work to do still as far as evidence goes. Something just a little controversial. So there are very strong caveats to the use of this technique, but in Northumbria, gradually over more recent years, and I'm aware that other centres also more recently have done this, we sometimes actually retain some distal femoral cement and do a cement-in-cement stem revision for infection. Now, this is a technique that was also done in Exeter, and we've written up a joint series with Exeter, which we presented at the British Hip Society in the summer of 21, with 89 patients who had cement-in-cement stem revision. Note, this is just for the stem. All the socket always comes out and is changed because that's easy. So this is just for distal femoral cement in the stem side. 89 patients, 92% remained infection-free at final follow-up at a mean of 56 months, minimum of 2 years, but up to over 10 years for some patients. But very, very strong caveats, and I say this is controversial because this is not an excuse for being lazy and leaving distal femoral cement because it's a bit tricky to get out. It should only ever be used by very experienced teams, and it must be based on seeing 2 X-ray views, orthogonal radiographs with very well fixed and interdigitated bone cement interface distally. So the cement must be very well fixed and also assessed intraoperatively to be well fixed. And only on that basis should cement ever be left. And on that basis, as you see from our results, it can work. So here's a case that shows that example, just the X-ray. So again, we've got that loosened line around the socket. This was the infection. But if you look at that femoral cement, everything below the lesser trochanter is a total whiteout and very well fixed. And that is a case where we did a cement-to-cement revision of the stem. Everything else comes out. The top of the cement mantle usually comes out as well. You can see a bit of a line in zone 1 and 7 there, and all that cement comes out. That's easy. But that distal cement, which often can result in perforations and fractures and difficulties at the revision surgery, if it's very well fixed may be left, but very much only for very experienced infection revision surgeons who've already got under their belt lots of experience with 2-stage and then single-stage, and only as part of an MDT. This is not for the occasional infection surgeon and not an excuse to leave foreign material down the femur, which can cause later infections. So rather than inclusions for single-stage revision, I put exclusions, which essentially is what Jason's already told us. You do need a reasonable host, so very immunocompromised hosts might lead you to believe your revision will not be successful and infection may recur, and on that basis we wouldn't do a single stage, we would do a 2-stage. Difficult to treat infections, so there's some examples there, but we're looking at multi-organism resistant organisms, so particular ones, rifampicin resistant staph scare us, Cipro resistant gram-negative organisms scare us, fungus scares us, and they would always get a 2-stage revision. But other organisms certainly can lead to 2-stage. And what I haven't put there but should have done is, again, the culture negative infections. If you haven't got an organism, you cannot do a single stage. It must be a 2-stage, as Jason said. Soft tissue compromise. In the hip, we can usually close it primarily, can't we? So that's not usually an issue, but you might want to consider 2-stage if you've got real huge soft tissue defects. Tricky bony reconstruction, Jason mentioned. I totally agree with that. If you can't reconstruct it soundly in a single stage without very complex implants that you'd worry if you've got a reinfection, then you're looking at a 2-stage. And I think it's important to mention surgical and MDT experience. Again, if you're a unit that's not doing a lot of infected work, I think as we move forwards, that may not be the case. But in current practice and around the world, if you're only doing some infected work, do a 2-stage revision. You're going to get into much less difficulties than trying to deal with things with single stage and refixing implants very soundly in a single stage and having to take them out again. So it's for experienced teams, and I say teams, that's surgical and MDT. So some take-home messages. Debridement, you've heard that a lot already tonight, and that's an absolute common theme that's the same for all these procedures that we're talking about. Any uncertainties about yourself, your team, the patient, the organism, do a 2-stage revision. And the MDT you've heard all about, there's our very dynamic MDT, and that is crucial to managing infection. And just hiding behind the MDT on the right there is the Hip Society Surgical Standard, which will be available on the website in due course, to guide all the things that we've said and guide you through investigation and management. Thank you very much for your attention and for inviting me tonight.
Tim, thank you very much. Fantastic, very clear, very, very nice presentation. Thank you, as they all have been. The take-home message, as you can quite see, is the surgical technique for the treatment of PGII is crucial, which I hope is probably the number one take-home message. Now we've got some questions come in. We've got a few minutes to deal with these. The first, really, which we'll take is from Sami Sidham, asking really about the place of synovial CRP, leukocyte esterase and alpha-defensin. So perhaps on the basis that Richard talked to us about diagnosis, Richard, do you want to take that one to start with?
Yeah, I can do. I think we could probably do a whole evening session just on that, answering that question. But what I would say is both the European Bone and Joint Infection Society guidelines and also the International Consensus Meeting guidelines discuss this from slightly different angles. There's a slight element of contention, which I don't think would be helpful to get into tonight. But essentially what you're trying to do is get all these diagnostic criteria together to give you the best idea of whether or not there's an infection present. In terms of leukocyte esterase, I think it's a very good, helpful, quick and cheap test because it immediately tells you on a urine analysis strip whether or not the leukocyte counts are likely to be very high, with a view to still sending the information away for definitive testing. But we do use that as an initial protocol. In terms of alpha-defensin, there are controversies, and I think that's probably one to explore elsewhere. CRP is obviously, again, very reliable.
Good. Thank you, Richard. Aware that time is moving on, we have actually a question from Jonathan Barrow. This is actually about knees. I know we're a hip society, but he asks a very sensible question about what techniques do people have for getting at the back of the knee if you're doing a dare? Anybody got a view on this? Jason, do you do a lot of knee exchange?
I haven't done any knees in over, I don't know, about 12 years. So no, right. I would be ill placed to answer that.
Perhaps back to Richard, perhaps.
So the only complex knee I do, I suppose, is a Dare knee, so I'm still not the best person to speak. But at the same time, essentially, as with any Dare, you remove the modular components. That will automatically detension the knee. But I'd suggest not doing that too early on, because essentially you want to get around as much of the soft tissues that you can expose with the tension still there a bit, so that you can actually get a good clearance anteriorly and working around the side of the knee. And then take the modular liner out. And again, providing you're protecting the metal surfaces, then also you can use laminar spreader to stretch things out a bit as needed.
Sure. Thank you. This shows that we deal with both ends of the femur from time to time, which is very healthy. No other questions on the chat. I've just got a couple here, one of which I wanted to put to Tim. You mentioned that you add 1 gram of vancomycin to your cement when you're doing a single stage. Is it possible in certain situations to add more? I mean, certainly where I work, we sometimes put in huge amounts, not necessarily at a single stage.
Compromise, isn't it, between the mechanical integrity of the cement and the amount of antibiotics. That was for that case. We will often put 2 grams of vanc in the copal. In a 2-stage, we would put a lot more, definitely, but slightly different for a single stage. There is some cement. There is already some antibiotics in that copal, of course, with the Gent and Clinda. So it has got some already. So we'd probably just use 2 grams there. But in a single stage, I'd put up to 4 grams per mix. I think Jason's...
Jason, what's your view?
Well, I am a cement geek, as you know. I did my MD on cement and antibiotic loading of it. So if you're going to add your antibiotics, as Tim said, if you've got to have less than 2.5 to 5% per weight in antibiotics. If you go above that, it's not strong enough. But for spacers and for a first stage, it's fine. If you're going to add your antibiotics, you've got to do it in a fractional manner. So if you put 1 gram of antibiotics in, then you add 1 gram of the powder and you mix those together. Then you've got 2 grams. You've then got to add 2 grams. It takes time, and people don't do this. You just see them sprinkle it on the top of your mix and mix it in, and you get a really bad mix, and you don't get sort of reliable, homogeneous release. So if you're going to do it, you've got to do what's called that fractional addition. And whatever you put in, it should be fine. You've got to make sure your antibiotics are going to work, because depending on some of their hydrophilicity, it's whether they're going to elute well. And as Tim has said already, if you compare, and I have done it, and other authors have done it as well, if you compare industry-made antibiotic-loaded cements compared to those that we add, you can add 4 to 5 times as much, and it still doesn't elute as much as the industry-made, because they have absolutely added it perfectly. And that's definitely experience they've had in the States as well, where for many years they've not had the ability to get off-the-shelf antibiotic-loaded cements. But yeah, you've got to mix it bit by bit.
Jason, thank you. Very clear, very good advice. We've got some more questions coming in on the chat. We've just got a few minutes to go. One from Richard King, actually. He's saying, when performing a revision, do the faculty delay giving antibiotics until microsamples have been taken? Always, never, or sometimes? Because I noticed, I think, forgive me, was it Tim suggested that at a single stage you often give IVs at induction?
Yeah, so we don't delay. There is literature that suggests the induction antibiotics don't affect your specimen yield, for a reasonable amount of time. So much better to have the antibiotics on board and stop the patient getting a new infection with your revision surgery. Yeah. So we give them at induction every time.
Okay.
I think Richard, that's a really strong message that's come from the international consensus and elsewhere. You're putting your patient at risk of getting infected in your infected revision if you don't give antibiotics. Yeah. Remember, the antibiotics you give in a broad spectrum, they do not penetrate the biofilm, and therefore they do not affect your yield from your sampling. That's old information to say withhold them.
Okay. Richard, would you have a contrary view or agree with that?
I work with Richard King, actually, so for me to start saying our unit's policy would be, but I strongly agree that, the risk of introducing infection is far greater.
Good. And perhaps the last question, we've got another one from Sami Sidham, who's just asking about the relevant place of chlorhexidine versus povidone iodine for your chemical debridement.
So we use povidone because I believe the literature is stronger for povidone, although none of the literature is incredibly strong for these things, but on balance we felt that the literature fell in the favor of povidone but it's hard to get sterile povidone iodine. We actually had to pursue a special manufacturer to get bottles of it. We use it for all our primaries, but it's not easy to get hold of. And in the deficits of that, you can also use very dilute chlorhex, which I think the Bristol group have published on, and that works probably as well. I don't think there's a clear literature to define which is best, or even if it's works, but we feel on balance povidone is where we're at. But I think using something's better than nothing personally.
Yeah, exactly.
Yeah, lots of lavage, lots and lots and lots.
Yes,
and it's the volume and the action that's probably more important than the element. Remember, bacteria have got resistance genes against antiseptics, just the same as they've got them against antibiotics, but it's not as well studied. And I don't think you need to be buying these extremely expensive bags that are now becoming available. So something simple like iodine, we use chlorhex, or if you can't get anything else, saline, just lots and lots, volume rather than what it's got in it.
Yeah, exactly. And the physical debridement probably more important than the antiseptic. Well, definitely more important than the antiseptic. Yeah.
And perhaps the final question. Perhaps the final question. One more from Chris Wakeling, just asking about the place of Stimulan. We have touched on that. I think we would agree that the data is probably a little bit controversial. But anybody got any quick views on the use of Stimulan?
I think it's bone and joint infection registry's got to give us the answer to that. That's where that's coming in.
Yeah,
I agree. Okay, I agree.
We don't know.
And perhaps on that note and that minor plug, Tim, we'll bring the session to a close. All it remains for me to do is to thank my co-presenters, Tim, Jason, and Richard, very much for a very interesting, stimulating session. As I said at the beginning, periprosthetic joint infection is the disaster. We can play around with robots and custom-made implants and approaches and everything else, but we've got to still work at getting rid of PJI. So hand back to Vikas for the final comments, and thank you all indeed.
Thanks a ton, Andy, and to all our speakers. And to those who missed it, please do log on to Panopto via the BHS website to watch it. Thanks a ton all. Have a good evening.